All right, I'm Dr. Martina Moore. I am the Substance Use Disorder Coordinator for the Clinical Mental Health Counseling Program department here at John Carroll. And I will be conducting your training today. The topic of your training is Opiate Use Disorder Education, Prevention, and Intervention for Educators. I will save about 10 minutes or so at the end for any questions that you may have. And then there will be a quiz following this as well. Okay? So let's talk about opiates. I'm sure all of you have heard of opiates or opioids before, and so we're going to talk today about what those are. We also are going to talk about ways that you can detect and deter if you see someone that you think may be using them, and some preventative methods as it pertains to being an educator. So an opiate is a natural pain remedy. It comes from the opium poppy plant, which is there on the screen, which is a really beautiful plant that they come from. Opiates are alkaloids derived from the opium poppy. It's a strong pain relieving medication. And that's really what opium is used for. It is to create pain medicine. Some of the pain medicines you may know of that are made from those are like morphine, codeine, heroin, and there's a whole long list of other opiates. So they are also opioids, so sometimes you'll hear the words used interchangeably. Opiates come from the opium plant directly. But then there are opioids, which are the synthetic pain medications. And they're partially synthetic drugs that are manufactured to work in a similar way to the opiates. And so they really work like opiates. There's the same response and the same reaction in the body to help to relieve pain. Their active ingredients are made via chemical synthesis, though. And opiates may act like opiates when taken for pain because they have similar molecules. So some of the types of opioids that you would have probably heard of is like methadone, and we'll talk more about that. Percocet or Percodan, the Oxycontin, the oxycodone, Vicodin, Demerol, Dilaudid, all of those, including the fentanyl, the Duragesic patch, as well, is also considered an opioid. But whether it's an opioid or an opiate, and you see the list here, they are still very addictive, and they are all used for pain. At least that's what they should be used for. Okay? So this is just a list of some of them, like Tylenol 3, Tylox, Vicodin, oxycodone, Demerol, Dilaudid, opium, Percodan, Percocets, all of those you would see that fall under this list. Normally, you get these medications if you went into your doctor and you got some type of surgery. If you were to have some type of oral surgery done, if you were to go and say, okay, I'm having some pain, they may prescribe you an opioid or opiates. But we'll talk about why we're having this training today and why we're hearing so much about this in the news. So both of the types of drugs alter the way pain is perceived as opposed to making the pain go away. They're not there to make pain go away. The goal of an opiate is for it to actually relieve the person of the pain, but not to make the pain go away. So if you think about it, once the medication is no longer in that person's system, then it would not be as effective. So what does that mean? Then the person still continues to have that pain and continue to experience it. So they attach onto molecules that protrude from certain nerve cells in the brain called the opioid receptors. And we'll talk about what happens in those receptors. Once they are attached, the nerve cells send messages to the brain that are not accurate measures of the severity of the pain that the body is experiencing. Thus, the person who has taken the drug experiences less pain. However, over time, once tolerance develops, experiences change. So what's tolerance? Tolerance is the amount that a person would need in order to achieve the same effect. So, for example, I'll use alcohol for an example. With any drug, a person can develop tolerance. So let's say that you started out where you would go hang out with your friends and you would have one beer. And you get a nice little buzz, and you're hanging out, and you're enjoying yourself, and you get in your car after you've made sure you've worn off from it, and you drive home. Well, in about a couple of months, you realize, oh, that one beer is just not giving me that same effect. So maybe I'll have 2 beers. And you have 2 beers, and then you get that effect that you're looking for. So what happens when tolerance develops is that we can continue to take more of a substance in order to achieve the effect that we want. And that's what happens with opioids and opioids. So some of the ways that people actually obtain painkillers, as we also call opiates, they are 55%, and this was a national study that was done, 55% of the people obtain them free from a friend or relative. You know, somebody might say, you know what, I got a back pain. You got anything for it? And they give them something. Or 7.1% say they get it from other sources, from other people. Or 4.4% obtain them from drug dealers or strangers. 4.8 took them from friends or relatives without asking, going into their home, going into their medicine closet. One of the things that's very common now for young people is to go raid their parents' medicine closets. And so they'll go in there and they'll take the pills and they'll use them or sell them. 11.4 bought from a friend or relative, but look at that bottom number. 17.3 were prescribed by their doctor, which is a significant number. And we'll talk about why that number is so significant. So nearly 50% of teens abusing prescription opiates find them in their homes, in the homes of family members or friends' house. Some teens are legitimately being prescribed opiate medications by licensed physicians. Many do due to injuries while playing sports. Others buy them off the street or at school. These type of drugs are highly addictive, and as the demand grows, so does the price grow. Some of the higher milligram doses sell as much as $60 to $80 a pill. One of the ones that they buy on the street a lot is OxyContin. You can get it for about $80 for 0.5 milligrams of OxyContin on the street. So all of this started, and we're prescribing, and the doctors are prescribing pain pills because of pain relief. Someone goes to the doctor, and the doctors are trained to do what? To relieve pain. When I talk to my friends who are physicians, the first thing they say to me is, what they drilled to me in medical school is that I'm supposed to make sure my patients are free from pain. As a matter of fact, you go into the hospital, what's one of the first things they ask you? On a scale from 0 to 7, what's your pain level? And many times people will say, oh, it's a 5, it's a 6, it's a 7. And when the doctor hears that, the doctor's saying, okay, this is something I need to treat. This is something that I need to relieve. So therefore, they have been taught to do what? To assess for what we call the 5th vital sign. What's your pain? But we are realizing that we need to shift that, and we'll talk about that in a few. The doctor's job is to control pain. You come in, I have pain. So what we're finding now, though, is because so many people are moving from opioids to heroin and other dangerous drugs, that there needs to be a paradigm shift in our mind and our thinking. And we need to look for other solutions to treat pain rather than using opiates as the choice. So physicians are trained to manage pain, and the answer for them are prescription opiates. But we're realizing it is the problem for all of us. We don't want to blame the physicians because they were doing what they were taught to do. They were doing what they thought was best. But now we're realizing that we fueled a problem in our society. So pain relief, opiates can relieve moderate to severe pain. If taken opiates 8 days or longer on a regular basis, withdrawal symptoms may occur and one may need to be weaned off. 13.5% chance of becoming addicted if you are taking them more than 8 days. If you're taking them more than 30 days, you have a 29.9% chance of becoming addicted to pain pills. So what we tell people is if you go to the doctor, what you want to do is look for alternatives. Now, the thing is, nobody wants to be in pain. Our society now is, okay, let's fix it. Let's make you feel better. We teach our children, oh, you fall down, let's get something for that. What do you need? You need a Motrin or you need something? When we need to begin to shift and look at other things and saying, okay, pain is a normal process to life. What's wrong with a little bit of pain? What is wrong with feeling some pain? But what we've done is we've done a shift and we say, oh no, it's a bad thing to feel pain. Now we're realizing that maybe we need to swing the pendulum back and look at, okay, can we begin to say, if you're having mild to moderate pain, and can we begin to teach our children at a younger age that it's okay to feel a little bit of that? It's okay to hurt. So when people use pain medications only to treat pain as directed and for a short time, they are less likely to become addicted. What I suggest always to people is to first ask for something that is non-addictive. Try it. Try it. And then if that does not work, try something else that's not non-addictive. And if that doesn't work, then talk with your doctor about trying something on a very short basis that may be an opiate. And you and your doctor can make that decision. But the key is you don't want to just jump into taking an opiate. I had someone just recently tell me that their child had broke their arm while playing sports. They took their child to the doctor. The child had fractured the arm. They had put it in a cast, repaired it up, and the doctor gave them a 90-day prescription of oxycodone. What's wrong with that picture? Now, thank God this parent was smart enough to say, I can't give this to my child. I can't give them 90 days. So what are we teaching our children? We're teaching our children what? You have a pain, you have something, we're going to go and get you a nice size prescription in order for you to treat it. Now go back up to that statistic I just showed you. 30 days or more. Even at 8 days, there's a 13.5% chance that a person can become addicted. That's still very dangerous and a risk we're taking. So prescription drug addiction occurs when patients develop a tolerance for the level of medication that they have been prescribed and no longer get the same level of relief. Patients may not have the same expectation for relief as their physicians. And what happens is that the patients will go in and say they want all the pain to go away. They don't want to feel anything. And so the doctor continues to, okay, well, let's up the prescription a little bit. Let's try it a little more. Let's shift this prescription. And so what we're realizing is when expectations do not match, the patients may take more of the pain medication than prescribed to get a higher level of relief and in turn develop drug addiction issues. And as we begin to look at preventative measures, it is my belief that we need to start looking at how we manage pain and how we treat pain and what we say about pain. So addiction is defined as a chronic relapsing brain disease that is characterized by compulsive drug seeking and use despite harmful consequences. It is considered a brain disease because drugs change the brain. They change the structure and how it works, and these brain changes can be long-lasting and can lead to harmful, often self-destructive behaviors. Addiction is a disease. Nobody wakes up one day and say, oh, I think I want to become a heroin addict today. It doesn't work that way. No. What happens is a person uses a drug, their mind responds to that drug, and there's a euphoric feeling that they enjoy. It is the best feeling that they probably ever felt in their life. And what they want to do is feel that experience over and over again. What they want to do is have that opportunity to engage in that, but not realizing the cost of that. So the cost of that is you're never really going to get that first high back. And so what happens is they continue to chase after that and trying to find that. And as a result, they lose everything else. So we will look a little bit later about how the brain is affected and what the brain says about all that. So again, substance use disorders are brain diseases mostly characterized by a person's inability to control his or her thoughts or intake of substance. And a substance use disorder develops after a substance is repetitively consumed and the brain readjusts to its consistent presence. Research has shown that adaptations in neuronal functioning occurs regardless whether a person is taking legitimate medication for pain relief, consuming 5 beers as a first-time drinker, or injecting heroin on the street. So when a person uses a drug, many times that drug will mimic many of the brain neurons. And so what will happen is that a person's brains will actually change in the way that that brain is structured. So for opiates, we'll look at that and how it actually changes it. But one of the things it does is it causes a person to develop what we call tolerance. And I talked a little bit about that. When drugs such as heroin or other opiates are used repeatedly over time, tolerance may develop. Tolerance occurs when the person no longer responds to the drug in the same way that the person initially responded. And stated another way, it takes a higher dose of drug to achieve the same level that it initially did. So that same level of that high, of getting high and enjoying that high, is what's tolerance. And then there's withdrawal that happens. Heroin and other opiates cause severe physical and psychological symptoms 6 to 8 hours after the last dose, and painful withdrawal gets worse as time passes. And this is one of the big pieces about opiates. So a person takes an opiate, and about 6 to 8 hours later, they begin to experience withdrawal. How withdrawal looks, it first starts out looking like a simple cold. Nose may be running, eyes a little runny, nose, ears may be a little scratchy, their throat may be a little irritant. It begins to look at, but then it goes full blown into body aches, cramps, vomiting, nausea, body pain, and it is horrible. And so for someone who uses opiates, the goal for them is not to go into withdrawal because it is so uncomfortable. No longer is it just to enjoy the high, because they get to a level of tolerance where it's not even about enjoying the high as much. It's about maintaining homeostasis in their body so that they do not go into withdrawal. And so these are some of the symptoms that we see, and the goal is to avoid a painful withdrawal. Remember I said after 8 days, withdrawal can occur for anyone, and it's extremely painful. So let's talk about the predisposition for addiction. People say, oh, well, how do I know if I'm going to be an addict? Well, we really don't know. We really don't know, but there are some factors that research has shown that could say that someone could have predisposition, such as genetic factors, account for about half of the likelihood that an individual would develop addiction. Maybe their parents had an addiction, maybe even their grandparents. Environmental factors interact with the person's biology and affect the extent to which genetic factors exert their influence. It may be that they grew up in a home where everybody's using, or that somebody's selling drugs, or they live in a neighborhood where that's happening. Resilience the individual acquires through parenting or later life experiences can affect the extent to which genetic predispositions lead to the behavioral and other manifestations of addiction. And it could be that they were very resilient seeing a parent struggling or having to see lots of trauma in their life. And so those would be some things also that could affect that. Culture also plays a role in how addiction becomes actualized in a person with biological vulnerabilities to the development of addiction. If it's culturally, if it's acceptable to use drugs at a young age, if it is acceptable to engage in those type of activities, there are some cultures where it is, then they could have a higher predisposition. Other factors, stress, trauma, lack of healthy support could also be a piece. But no single factor will determine whether a person will become addicted to drugs or not. There really is not. And I tell people it's like playing Russian roulette. When you try a drug, you don't know until you try that drug what your response will be. And so we can list all the factors and we can look and say, oh, you got this one, or you have this one, or you have this one. But that does not necessarily mean that. It all depends on what happens in your brain when you make that decision to put that drug in your system. So what's the problem? 1 of 5 patients without non-cancer pain or pain-related diagnosis are prescribed opiate pain medications. Nearly 2 million Americans abused or were dependent on prescription opiates in 2014. Between 1999 and 2015, more than 180,000 people died from overdose related to prescription opiates. And that number has climbed so much more since then. As many as 1 in 4 patients prescribed opiates for chronic pain develops an opiate use disorder. You see that number, 1 in 4. So we can count in this room. That means 2 of us would become addicted. At least 2 of us, if we were prescribed those for chronic pain. So prescription opiate abuse often leads to heroin abuse. 4 out of 5 new heroin users started misusing prescription opiates first. That's where they started. Now, though, we are finding, because of all the things that are happening within our legislation, and they're changing things, that we are finding more people going straight to heroin, but most of them start with prescription pills. So let's talk about what happened, the shift. So we have the growing opiate addicted population, more people being prescribed opioids. We had the shutdown of the Southern Ohio pill mills, and we'll talk about those in a minute. We added scrutiny on prescription opiate pills for the doctors. We added tamper-resistant, long-acting prescription opiate formulations. We increased the supply of heroin, and we'll also talk about that. And we decreased the cost of heroin, which in turn increased the purity of heroin. And so therefore, it was a recipe for disaster of where we are now. This is what's called crude heroin. It's dark. It is the heroin. Most heroin is white when it's purified, but this is what we call dirty basing. It's the dirty heroin that people would use, and is the one that has been cut with other items. It's a cheaper form of heroin. This here is more in the raw form, the white ones that you see there. That is the rock form. Sometimes they'll smoke it in that form. Over there, you'll see the black tar there. This is some of the paraphernalia, and we'll talk about signs and symptoms to look for, such as spoons, needles, baggies, foil, all of those things. Those are all heroin paraphernalia. Track marks. You will see track marks now. Many of the people will shoot up in places where you don't see them as obvious, not in their arms, but they'll shoot up in their buttocks. They'll shoot up in their legs. Other places that I would care not to say, but there are other places that people will now actually inject. Many of them do still shoot in their arms, but there are other places that they do as well. So that's a syringe, and that's what it looks like with heroin in it. That's actually a heroin addict mainlining his drug. So what are we seeing here in Ohio? Let's talk about it. Over 4,000 overdose deaths per year. Per year. That is 11 overdoses per day, every day of the year. So besides working at John Carroll, I also own several outpatient treatment centers for substance use disorder. And on any given day, we have clients who die as a result of heroin overdose. And it has gotten to the place now where we cannot even keep up with the volume of what's happening. And it's very sad what we've seen. People say, well, why here in Ohio? And we're going to talk about why Ohio is the center of this whole problem. So to understand how heroin took hold in rural America, you need to go back 2 decades and look at the surge of prescription drug use in Portsmouth, Ohio. It was the pill mill capital of America. Portsmouth, Ohio is in southern Ohio. They have more pill mills per capita in that town than anywhere else in the country. Pill mills are where doctors prescribe pills for almost anything without any pain or any problems. And the patient goes in, you can tell the doctor, oh, I've got a backache. Doctor does a minor little assessment on you, and they give you a prescription, and you go off and actually they don't give you a prescription, they give you pills for cash. You get the pills there for cash, and you go off with your pills. And so we had this happening for years there. There were people coming from Canada to the pill mills, Kentucky, West Virginia, all over to this little town in Portsmouth, Ohio, where they were getting the pills. They had dozens of these, and they prescribed millions of pills a year, and was one of the main reasons why so many people got addicted there. So, oh, my clicker isn't working. So then what happened was our governor, rightfully so, decided that we need to crack down on these pill mills and we need to shut them down. And so the governor developed a task force who set up a strategy to close the pill mills. But what we did not realize and what we did not prepare for was that when we shut down these pill mills, so you have all these thousands of people getting pills. Now remember, heroin is physically addictive, so they're physically addicted to the heroin. So what happens when they go to their doctor's office and the doctor is shut down? They can't get their pills anymore. And they can't go to a legitimate doctor, because a legitimate doctor is not just going to prescribe them something because you say this doctor down the street here was giving them to me out of a baggie. It's not going to work that way. So then they went to the fallback drug, which is heroin, because remember, they had to avoid the withdrawal. And at the same time, the Mexican cartel stepped in, providing home delivery for addicts. So the Mexican cartel actually looked at Ohio, realized this is going to be the great place to go, and set up our operation. And so they set it up where they were selling heroin, replicating it far beyond Portsmouth, Ohio, with black tar heroin, which was cheaper and more potent. And hence how the problem began in Ohio. There's a book out that you should probably read about this. And it really talks about how we got here. And it's very sad the way that we got here. But we are there now in the middle of it. And so we found more and more people turning to heroin because they could not get their pills anymore. And then there was the fentanyl crisis. Okay? So fentanyl, which was on the list, is an opioid. Synthetic and short-acting opioid. It's 100 times more potent than morphine. So morphine is the standard of how we standardize and we compare all other opiates. Fentanyl is 100 times more potent. It's 50 times more potent than heroin. Primary use is for managing acute pain. So the drug dealers started cutting heroin with fentanyl. So you say, well, why would they do that? Money. Because for a heroin addict, if I'm using something that's stronger and more potent, and even something that's going to knock me out, where I actually stop breathing, it's a good batch. And I want more of that batch. So I know you're probably saying, that's some sick thinking. Well, addicted mind is really sick. And the addicted mind is all about what? Getting that high, getting that feeling, and not feeling the withdrawal. So if you look, this is a lethal dose of heroin. This is a lethal dose of fentanyl. Doesn't take much. Let me give you another comparison. That is a legal dose, a lethal dose, I should say, of fentanyl. I'm going to back up, compared to heroin. So how much money do these drug dealers save? Because they take less of this and they save this and they cut it with this, which gives them a better high, and they can sell more of it. You see? So you say, why would somebody do that? For money. That's why they would do it. So fentanyl-related deaths and reported seizure cases between 2013 and 2015. In 2013, the high month in November was 40. In 2014, high months were March and December. March had 200. These were overdoses or seizures. December was 260. In 2015, in December, they had 475. This is in Ohio. And it's still growing. It's much larger than that now. And we're in the end of 2017. But then someone says, okay, carfentanil. Now, carfentanil is the one that's really scary. It's a synthetic opiate used by veterinarians to sedate large animals such as elephants, and is not intended for human consumption at all. It's up to 2,500 times stronger than heroin. Huge, right? It emerged recently in Ohio. It's extremely lethal and immediate death for many who take it. Immediate. This was created for elephants and giraffes and those large animals in order to sedate them, not human beings. Human beings aren't even to come in contact with this. The Washington Post reported that Ohio is ground zero for the drug carfentanil in the United States. A tiny dose, a fraction of the weight of a paperclip, could send 500 people to the morgue. They only need that little bit. So imagine how much money the drug dealers are making, because they can take that little piece, spread that out for about 500 people with a little bit of heroin, and get them high. But they're killing them because it's so lethal. Fentanyl, heroin. Carfentanil is 100 times more powerful than fentanyl. So, let's talk about why people overdose. We're going to go back to the brain. So opioids fit into specific pain receptors in the brain, which affect the drive to breathe. It suppresses the central nervous system. So there's your opiate, there's the brain receptors. It fits exactly onto the receptor. And what it does, it stops the person from breathing, and it depresses the central nervous system. So what happens is when they take something that strong, they don't actually, it's not because of the drug, it's because they've suffocated. And that's what they die from, is because of that. So overdose can occur immediately after drug ingestion, or could happen hours after the drug. Overdose can last up to a couple of hours, where the overdose victim experiences respiratory depression. And fentanyl-related overdoses tend to happen instantly. We see it. Narrow window of time available to rescue the victim, require additional doses of naloxone to reverse the effects of opiates, and victims die from suffocation, not the drug. And we'll talk about what we do when we do have people that overdose, which is here, the Narcan. So naloxone, also known to many by its brand name Narcan, has saved tens of thousands of lives by reversing. I tell you, as an educator, as a student, as a mother, as a father, everybody should have one of these kits. I have had to use this kit in the last couple of years at least 6-7 times myself. I have had people that I know that say, I was at the store, I looked over, saw somebody had passed out, I had to use my kit. Everybody should get a kit, and they're free. You can go get them, but as an educator, as a professional, you should have a kit. This is actually the antidote. It reverses the effect of an overdose. So what happens, we actually spray it up their nose, and I'll show it to you in a second, the intranasal medication, and we see them immediately come back, unless they're on fentanyl. On fentanyl, I had a patient that was on fentanyl. He was coming to my office to see me for an assessment. In the parking lot, he used, overdose. They came to get me. We go out to the parking lot. We gave him 3 of these. He didn't come back. We started doing CPR. He started coming back. Called EMS. EMS comes. They had to give him 6 more. That's how strong it is with the fentanyl. And that's how much it's taking for us to revive them. And sometimes we cannot. And the carfentanil, it doesn't even touch them. It's not even an option. So let's talk about recognizing the signs and symptoms of drug use. You may see needle marks, red eyes. You may see how the person is putting it up under their arm there. They'll put it up under their armpits. You will see pinpointed pupils. You see how the pupils are doing that? And so signs of being under the influence of an opiate, heroin or fentanyl, and the pupils will actually constrict that way. And normally you couldn't get your eyes to do that, right? But if you see someone high under the influence, you'll see their eyes doing that. Now, I've seen it, and it looks really scary when you see it. Like, what the heck is wrong with your eyes? You'll see drowsiness or being lethargic or nodding off, what we call it. Scar or track marks, excessive scratching at the skin, because some people are actually allergic to the opiates. And that is one of the side effects of an opiate, is it causes itching. Blank stares, slow reaction to time, slow speech, or shallow breathing. So as educators, what you need to look for, a survey of 9,000 patients at treatment centers around the country found that 90% of heroin users are white men and women. Most are relatively young. Their average age was 23. Many stated they first started using opiates between the ages of 16 and 17, and 3/4 said they first started not with heroin, but with prescription opiates like OxyContin. So what you should look for is students with legal prescription, if someone has a prescription for it. Athletes with injuries is a big piece. Pill parties. These kids will have pill parties, and what they do is they raid their parents' pill cabinet, and they'll take the pills and they'll take them to the parties, and they share pills and they use each other's pills. Paraphernalia, some of the paraphernalia I showed you, the needles. Aluminum foil, that's a big one because that's what they carry it in, and that's what they smoke it off. I often tell the parents, if you find your spoons missing, that is a sign that something is probably going on. Spending a lot of time alone, loss of interest in favorite activities, unkept physically, multiple injuries. Sometimes people will on purpose hurt themselves. I've had patients fall down the steps and break a leg so that they can get a prescription. Or they will complain that they've had multiple injuries. Or ongoing complaints of pain constantly. You want to look for people who may consistently very tired or lethargic. Because remember, it suppresses the central nervous system, so they get tired. Sad mood, nervous or cranky, quickly change between feelings of feeling good and bad, nodding in class throughout the day, not completing assignments, missing class more often, again, track lines on the body, and having a cold more often or being sick. One of the first symptoms is having a cold because what? They're in withdrawal. They haven't had the drug. So that would be one of the things that you would see. So what you also want to look for is to tell parents to be aware of missing spoons, students having aluminum foil in their room or in their car or on their possession. I just had a parent, she told me I didn't even get it. Her 17-year-old is addicted to heroin. She said she just kept buying more spoons and couldn't figure out what was happening to him. And it wasn't until she got a call from the police and they said that we have your child here and they've been arrested for heroin possession, that it hit her that all the spoons have been missing in the house. Rolled up dollar bills, because they'll take the dollar bills and they'll roll them up and they'll snort it that way. Or tattoos increase to cover track marks, because they'll increase their tattoos. If they're wearing long sleeves in the middle of 90-degree weather, that ought to tell you something. They're trying to cover up something. Or long pants and it's hot all the time. You want to look at those things. So let's talk about preventing drug abuse and addiction and how you can help prevent this. Well, first of all, we want to educate our preteens and our teens about the harmful effects of opiates and their potential leading to heroin. We want to educate them at the youngest age possible. We want to explain that just because a pill is prescribed by a doctor doesn't mean that it's okay and you cannot become addictive. That is what so many people believe. They believe, well, if the doctor prescribed it, it's okay. No, doctors can prescribe medications that you can become addicted on. So we need to explain that to them. We need to also educate the parents about the use of opiates and the addiction potential, because parents will leave opiates around the home. Parents will encourage children to take medications. They'll allow their children to take medications for simple things. So we need to explain to them the risk as well. We need to educate athletes about the potential risk with injuries and being prescribed opiates. And we need to watch our athletes. We need to educate and not scare tactics. We don't want to scare them because you can't scare these kids. It doesn't work. But we want to use education and tell them and help them to derive of, okay, this is not the best choice for me. We also want to do random urine drug screens. Many schools are now going to random urine drug screens, and I think that's a wonderful process. It's a very good preventive tool because if they know, okay, at some point I'm going to get tested, and if I get tested and test positive, there's going to be a consequence. That's a great thing. And it's setting them up for the real world, because when you go get a job, the same thing's going to happen there. We want to educate parents about prescription medications in the home and tell them to either lock them up and how to properly dispose of them when they are done with them. We want adults monitoring parties and other social events, and not just letting our children go off to parties, not knowing where they are, not knowing what's going to be happening there, and not knowing if there's going to be adult supervision. We want to educate the parents on the importance of alternative pain management options other than opiates for children, and I say other than any other medications. We want to first try other alternative things for pain. There are so many holistic choices for pain now that we don't have to start with this, unless it's something chronic, unless it's something where someone is dying and they're on their deathbed. But to say, okay, my child fell off the swing and they need an opiate, or my child got kicked by a ball, and even needing a Tylenol. What we're teaching them is that something happens, you experience pain, and I need a pill to help take care of that. And so we need to teach parents, let's begin to change that shift and how we respond to this. 2016 statistics, a new study finds that the number of Americans being diagnosed with opiate addiction continues to skyrocket, but very few of them receive treatment. Very few people receive treatment, even though our treatment centers are full. If our treatment centers had everybody in them that we needed, we wouldn't be able to handle it. So the goal of addiction treatment is always to assist the client in stopping the compulsive use of drugs or alcohol and progress them to living a normal life again. Addiction creates a host of negative effects to the dependent client, his or her family and friends, and society as a whole. And research has shown that the most effective treatment regimen for opiate use disorder is a combination of what we call medication-assisted treatment and then behavioral therapy, such as cognitive behavioral therapy and person-centered therapy. So we're going to talk just a little bit about medication-assisted treatment. So the single most accurate predictor of successful treatment outcome is the length of time a person is in treatment. The longer that they're in treatment, the better the outcome is. And research supports that now, and we understand that. So our goal is to help the client to stay in treatment longer. The longer they're engaged and the longer that they're involved in treatment, the better chance that they have of being successful of not relapsing. So we want them to achieve abstinence. We want to help them to prevent relapse and decrease the frequency and the amount of their consumption, and help them to continue to stay committed to meeting their treatment goals. And medication can help as a tool with that. So what we do is we give them medication to assist them so that they will engage in treatment. So in the state of Ohio, there are 3 forms of medication assisted treatment that is approved. But before we talk about that, let's just show it decreases in the number of overdoses for heroin abuse. It increases retention of patients in treatment, and it decreases drug use infections and disease transmission, and it decreases criminal activity. And that's really what we all want to see. We want to see people stop using. We want to see people be productive citizens in society. We want to not spread diseases, and we want to stop criminal activity. So the 3 types of medications, there's 3 types, one that we call a full agonist, a partial agonist, and an antagonist. And I'm not going to go too much into this, but I'm just going to explain the 3 of them to you briefly. The first one, which is a full opiate agonist, it attaches itself to those opiate receptors. Remember those receptors I showed you? In a similar manner as opiate drugs like heroin or OxyContin. Methadone is a full agonist, which means if we put a person on methadone, they don't have to withdraw first. If someone came in and they said, okay, I'm on heroin, I want to stop using, I want to go to the methadone clinic, we can give them methadone right then and there once the doctor sees them, and they will not experience any withdrawal. Remember, the goal is they don't want to experience withdrawal. But what happens is the full agonist prolong dependence on opiates, because then they become dependent on the methadone. They don't get the high that they would achieve on heroin, but it stops them from going into withdrawal. So a person could be on methadone for years. I've had clients who have been on methadones for 20, 30 years in order to avoid the withdrawal and to avoid them from going back to those old behaviors. But if they come off of it, then they go into withdrawal. So we will see them relapse again. So then there's a partial opiate agonist, which is Suboxone, or you've heard buprenorphine is a partial agonist. Partial agonists still stimulate the brain's opiate receptors, but not as much as a full agonist. So one does not have to withdraw again before starting this, but if one stops this abruptly, they will experience withdrawal. So this one, it does also prolong their dependence on opiates. Because again, it sits on the receptor, it acts like, almost like heroin. They don't get as high as they would on heroin or other opiates. It'll give a mild stimulant, but it stops the withdrawal. And that's what they want to see. People go to Suboxone clinics, they'll go into the doctor's office. Usually the doctor will give them a prescription for a week, 2 weeks, even a month, depending on how the patient does. The problem we've seen with this is the diversion problems, because unless they take it, then it's no good. So we'll have patients who don't necessarily take it, or they'll sell their Suboxone to other people, and all types of things we've seen happen. And then there's naltrexone, which is Vivitrol, which is a full antagonist. And the difference with this one is they must be withdrawn already. So this is non-addictive, and it will not lead to physical dependence. But the problem is that they have to be withdrawn already. So, and withdrawal takes about 7 to 10 days. And remember, I told you, it's very painful. The great thing about naltrexone, though, it also comes in a 28-day injection. And so we can give them the injection, and for 28 days it's in their system. And if they try to get high, they cannot. Because this is an antagonist, it sits on the receptor and it blocks the receptor, that they will not respond to any opiates whatsoever if they would try to get high. But they could overdose, because remember what I told you about the central nervous system, that they can flood the system, suppress the central nervous system, and still die off of it if they were to try and not even feel the high. So those are the 3 medication-assisted treatments. But that's only one aspect of treatment. The medication is intended to help prevent relapse while the individuals work on long-lasting behaviors. We usually do not put a person on a medication-assisted treatment unless they are motivated to make change. Because if not, then we're just enabling them, or we're really helping them to really overdose and die, and we don't want to do that. A full treatment continuum should take place along with medication-assisted treatment like counseling in order to have long-lasting recovery. This is where we'll stop and take any questions. So the question is, what would stop a person from getting Narcan over and over again, knowing that they could get it and just go out here and continue to overdose? And what I have found, and this is what I have found, is that most people using heroin, they don't like Narcan. Because what happens is when we give them Narcan, they immediately go into withdrawal, and they wake up and they are pissed. They're angry. Because first of all, we've messed up their high. And second of all, they're going into withdrawal. And for them, that was the best high that they ever had. They don't realize, oh my God, I just died. They're just thinking about where I was and I was enjoying that high, and you messed it up. So I don't see people out here saying that's the last thing on their mind. What's on their mind is to get that next high and to feel it over and over again. Other questions?
What are your suggestions on, schools implementing policies more in depth?
So one of the ways we can inform educators, and that's a great question, I think, is to stay abreast and stay on top of it, and constantly have forums where you're talking about it and bringing experts in to talk about what we're seeing new. We're seeing so many new things. And I'll give you an example now. So they're mixing fentanyl with cocaine, and then they're mixing it with marijuana now. And unless we inform, you don't realize it. And so the information has to happen. The other thing is our police forces are now getting very good at this, and they are out educating the public. They're enjoying coming into schools and talking to the parents and talking to the educators about what they are seeing out there. So I think that we need to continually provide forums where we're all getting educated, and then we're taking it to our children, we're taking it to the parents, and everyone else gets the education that they need. Yes?
I guess my question is, so like you work at a rehabilitation center, so you know people that like pass out or such, like you can give them that drug, right, to revive them. So you know that they're on a drug dependency, but I don't know, we're in a classroom and that happens. How do we know that it's drug related?
That's a great question. So you don't, but the great thing about Narcan is you can give it to them, and if it's not, it will not harm them at all. There are no harmful side effects. So we tell people, caution on the side and just give it to them. If not, nothing's going to happen, and you will not be liable for anything. Yes. So that's a great question. Yep. Yes.
Another question that has to do with the Narcan, the thing that helps reverse the effects. You know, as future educators, you know, are they provided in clinics at the school? I personally didn't know that.
Yeah.
They were free.
Yeah.
Offered to teachers or faculty before this talk. So are they offered, and where can we get them other than maybe the schools? Or and you said maybe to have them on our person. We see it out in the community, at our homes, family events, or anywhere in general.
That's a great question. So you can get them from the free clinics in your community. Any community mental health clinics will provide them. You can call them. You can call 211, which is the mental health hotline, and ask them where in your community can you get a Narcan kit. So they'll let you know where you can get one. You can also go to the pharmacies, and they are putting together some rules for the pharmacies where you can get them for free. So they are also, you can also get them from pharmacies as well. Yep. Any other questions? Okay. Well, you guys have been great. I will pass on the slides to Lisa so that she can share those with you. And thank you for being such a great audience. You're welcome. All right.